So at this time, I'll take a moment before each speaker, rather than summarizing the experience and the wealth of knowledge that each speaker bring. I'll take some time prior to the introduction of each speaker to explain a little bit about their professional biography and why we're excited to have them here this evening with us. So at this time, it's my pleasure to introduce Dr. Sara Thorne, a leading cardiologist specializing in adult congenital heart disease and obstetric cardiology. Dr. Thorne is based at the Peter Monk Cardiac Centre in Toronto and previously spent 20 years at University Hospital Birmingham in the UK, where she established a renowned adult congenital heart disease unit and obstetric cardiology program. Dr. Thorne has a deep expertise in managing cardiovascular risks, particularly in women with congenital heart disease during pregnancy. She also serves on GADA Canada's professional advisory board and is highly respected for her work in aortic conditions. Tonight, she will share her insights on the diagnosis, misdiagnosis, and medical management of aortic dissections. Please join me in welcoming Dr. Sara Thorne.
So thank you very much. Hopefully you can see my slides. Are they on presentation mode yet? Probably not. Hold on.
Yes, we can see your slides.
Yeah. Mm-hmm.
Thank you. Well, thank you. This is it's a great pleasure to be with everybody today and to join in with this in this webinar. And I think my talk really is just a general introduction to how not to miss the diagnosis of aortic dissection. And I think it's great that GADA has taken on this raising awareness program for Think Aorta. It's such a simple message. Aortic dissection is an emergency. It's often fatal if it's missed. And this is an initiative that started in the UK, and I'm really pleased that GADA has taken it on and bringing this message through to the emergency departments across Canada to improve the speed at which dissection can be made. The Think Aorta program is really simple, and it's to help emergency physicians to think about dissection as a possibility. There are many causes for chest pain that patients come into the ER with, but for dissection, pain is usually really typical. It's severe. It can be in the neck, the back, the chest, the abdomen. It can be associated with weakness and be associated with collapse. It's often very sharp and tearing and ripping, and whoever has a dissection knows something really bad is happening. Despite that, it's often misdiagnosed as something else, or another condition is excluded and the patient is sent home. There are risk factors to consider. So in anyone who's hypertensive, who's known to have aortic disease or has a bicuspid aortic valve or a family history of aortic disease, or has Marfan syndrome or other connective tissue disorders, whether they're syndromic or non-syndromic, these patients are at really high risk and should never be sent home without a confirmatory diagnosis. Physical exam may be helpful. There might be a deficit in pulse, so the pulse may be stronger or weaker in one arm. There may be neurological signs. And really important for clinicians to understand is that the basic initial tests, chest x-rays, ECGs, and so forth, can be normal. So unless you think of the aorta, it's something that can be easy to miss. So what is an aortic dissection? Well, it's a tear in the inner layer of the aorta so that blood can then flow through the tear and cause a split between the inner and middle layers of the aorta. And there are different types of dissection. Type A always involves the ascending aorta, and that's this first part of the aorta as it comes out of the heart before it comes round the arch and then down to the rest of the body. A type B dissection does not involve the ascending aorta, but does involve the descending aorta. So type A can also involve the whole of the aorta. So why does it matter? Well, it can lead to rupture of the aorta and death. but it can also cut off blood supply to the vital organs and cause strokes, heart attacks, bowel and kidney injury. And it can cause a condition called tamponade, which is where blood that's come tracked down from the torn aorta gathers in the bag around the heart and prevents the heart from relaxing to fill with blood, and therefore makes cardiac output fall and puts patients into shock and can result in death. CT scan is the gold standard for diagnosing an aortic dissection, and I'll talk through these. Where I've written AA, that's the ascending aorta, and DA, that's the descending aorta. So with this picture with the gold image, you can see it's like a 3D reconstruction. The ascending aorta is dilated. It should be the same, similar diameter to the descending aorta. And here you can see this line through the ascending aorta, and this is the line of the aortic dissection. That's quite a fancy image and maybe not produced at 3 o'clock in the morning if somebody goes into the ER with chest pain, but these images certainly can. So this is a cut, a vertical cut through the body to show the aorta. And here again, here's the ascending aorta, the arch of the aorta, and the descending aorta. And you can see it's not particularly dilated, but you'll see as well there's a line that comes down the descending aorta, and that is the aortic dissection. And then this is a cut transaxially through the body. So the front of the chest is at the top here, the back of the chest and the spine is at the bottom here. This is the ascending aorta, which is dilated. This is the descending aorta, which looks of normal size. And you can see here is the line of dissection. And you have it's hard to say which, from this image, you have a true lumen and a false lumen with blood going through. And you can see in white here, this is where most of the blood is flowing through, with less blood flowing through this lumen. I have a very useful Canadian clinical practice guideline produced about 4 years ago. That's a very simple document for clinicians. It underlines the importance of understanding that good outcomes depend on a rapid diagnosis. We know that mortality for a type A dissection increases by 2% every hour, so it really is important to think and act quickly. And for 25% of people who have an aortic dissection, the diagnosis can be delayed by 24 hours after arrival at the ER. And of those, about 30% is not made at the first ER visit and is diagnosed at a subsequent visit, or really sadly at an autopsy. The key test is going to be an EC-gated contrast CT, but it has to be used effectively. And inappropriate use means unnecessary radiation exposure to the patient, risk of reaction to contrast. You may get a false positive where we think that means it looks like a dissection and it isn't, or it may delay people who are very well being discharged from the emergency room. And there's also a cost involved. So there's clearly a need for a risk assessment so clinicians can make a decision about whether a contrast CT is necessary. And this risk scoring system is really quite nice and simple. And it looks at four risk assessment categories. The first is risk factors. Is there a history of connective tissue disease, whether it's a syndromic or a non-syndromic thoracic aortic disease, either in the patient or in the family? Is there existing aortic valve disease? Has there been an aortic intervention recently? Is there a family history? And is there a pre-existing aortic aneurysm? And for each of these, you'd score 1 point. You'd score 2 points if you had a pre-existing aortic aneurysm. Then I mentioned that pain is usually a very key feature for an aortic dissection. And it can be the most severe or worst ever pain. It can be described as thunderclap, tearing or ripping, or migrating or radiating. So it might start in the chest and go to the neck or down to the back or the abdomen. And again, we score points for how many of these high-risk pain features the patient may have. And then on physical examination, so what the doctor sees, is there a difference in pulse between the arms? Are there unexpected neurological symptoms? is there clinical evidence of aortic valve regurgitation, aortic insufficiency? And is the blood pressure low, or is there a pericardial effusion, which might mean tamponade? And then on the other side, is there a possible other diagnosis which may be more likely? And you add up these risk scores. Oh, and apologies. Pregnancy or being postpartum should be considered an additional risk factor because it is a condition. Pregnancy is a condition that makes aortic dissection more likely if you have underlying connective tissue disease. And then with your score results, if you score nil, you've got a low risk probability of having an aortic dissection, and further investigations are not needed. If you score 2 or more, there's high risk, and therefore a CT scan should be performed. If you've got 1, that you're on moderate risk, and therefore you might consider doing a blood test called D-dimer, which is often but not always raised in aortic dissection. So we can look at it in a different way. So if you have a moderate risk probability, a D-dimer blood test can be useful. If it's normal, you don't need any further investigations. If it's elevated, you need an ECG-gated CT of the aorta. Just an aside, if you're pregnant, a D-dimer is not very helpful because normal pregnancy will cause it to be elevated. Low risk probability, no further investigations. High risk probability, you need an urgent CT aorta. If we look then as well at the 2022 American guidelines for the diagnosis and management of aortic disease, there's a nice pull-out of the signs and symptoms of an acute aortic syndrome or dissection. So on the left of the slide, this is what a doctor should look for, but what should we think about as being a patient or a family member coming to the ER? Well, pain again is the cardinal factor, chest, back, abdomen or neck. Shock, and that can be a feeling that you're going to faint, you might be very cold, or sometimes people with an aortic dissection have an overwhelming feeling of impending doom. The pain can be associated with breathlessness, with symptoms of a stroke, or of bilateral leg weakness or pain. And it can also be manifest in blood, in the vomit, in the sputum, or in stool. The AHA and ACC guidelines also come up with a way of scoring the probability of risk in a similar way to the Canadian guidelines. So if you have a high-risk condition, a connective tissue disease, whether syndromic or non-syndromic, family history of aortic disease, pre-existing aortic valve disease, recent aortic surgery, or a known aneurysm, you score points. If you have high-risk pain features or high-risk examination features, you score points. So again, if it's low risk with a score of 0, then aortic dissection is unlikely and a CT scan is not necessary. If you score 1, moderate risk, you should consider a CT scan. If you score more than 1, you count as high risk and an urgent CT scan should be performed. So in summary, rapid diagnosis is crucial to survival in aortic dissection. And the key is to think aorta. And we need to do that in 2 ways. 1 is to help patients and their families to advocate for themselves. And 2 is to educate the emergency healthcare workers to think about aortic dissection, to do a risk assessment, and if there's a score of moderate or high risk, to carry out a CT scan without delay. Thank you very much.
Thank you very much, Dr. Thorne. We have a couple of questions we'd like to share with you. The first is from an aortic dissection survivor here in Canada who said she had no pain at all, and she's heard the same from others. How would you respond to that? And do we have any information on what percentage of those experiencing dissection experience it without pain?
So I think it's unusual. And I think one of the things you said at the beginning in your introduction is everybody is different. So yes, pain is usually the classical feature, but we all of us who look after people with aortic disease know some patients who've had no pain. and their dissection may have been found as an incidental finding, or they may have had other symptoms like neurological symptoms that mean that there's a further delay in diagnosis.
Yeah, which is the challenge.
I think that's a real issue. We don't have numbers to say what percentage of people, but it's the overwhelming majority will have significant pain.
That ties into the second question. You mentioned, this is our participant's question, you mentioned neurological stroke as one symptom. Can episodic TIAs over a prolonged period of time in someone with a dilated aorta, but showing no other symptoms, be indicative?
It would certainly it wouldn't be a classical symptom, but it would certainly raise awareness, raise my suspicions. Anybody who has a known aortic aneurysm and aortic disease who has any sort of neurological symptoms would always make you think, could there be a change in the aorta that's causing that? Or whether there's an extension into a head and neck blood vessel. Because obviously if you have aortic disease, many of the conditions that have aortic disease can also affect the blood vessels in the head and neck as well. Yeah.
One last question for you before we move on. I may need my entire descending aorta replaced due to type B dissection. Will I be safe to be physically active ever again after surgery? So yes, that's probably a common question, and a lot of people.
It's a super common question. So yes, absolutely, you will be safe to do exercise, but you need to be guided by your healthcare professional about what level of exercise and the timing of starting, because clearly there's going to be recovery time after your surgery. But with that guidance from your healthcare professionals, yes, indeed, the aim is that you should be active again and have a good quality of life.
Yeah. Okay, great. Thank you so much. At this point, it is my pleasure to introduce Dr. Dianna Milewicz, a globally recognized expert in the field of genetic aortic disorders. Dr. Milewicz is the President George H.W. Bush Chair of Cardiovascular Medicine and Director of the Division of Medical Genetics at UT Health in Houston. She has dedicated her career to advancing our understanding of the genetic causes behind aortic diseases, making significant contributions to the field through her research and leadership. Dr. Milewicz also serves as the Executive Chair of the Montalcino Aortic Consortium, which is the largest genetic aortopathy research registry in the world. Her work has been instrumental in identifying key genetic variants that influence the risk of aortic dissection, improving diagnosis and treatment for patients worldwide. We're honored to have her here with us today to share her insights on the importance of genetic testing and cascade screening in managing aortic dissections. Welcome, Dianna Milewicz.
Yes, thank you. Thank you for that nice introduction. And Dr. Thorne gave a great introduction to aortic dissections and the symptoms of them. Can everybody see my slides okay?
Yes.
Okay. So I'm going to talk to you about the fact that this condition has a genetic basis, and we can use that information to prevent sudden deaths in people that are at risk for aortic dissections. This has already been reviewed with you that, hold on just a second, that an aneurysm is an enlargement of the aorta, and the natural history of these aneurysms are that they progressively enlarge over time. That tends to be totally asymptomatic, and they reach a certain size where they're at risk to drive an aortic dissection. And our data say that 50% of the people that have this type of aortic dissection, that type A dissection, will die without even making it before they make it to the hospital. And it's still deadly, even if they make it out to the hospital, because they need their emergent surgical repair of this part of the aorta. But if we can figure out who's at risk, we can monitor the aneurysms, and when they reach a certain size, we can come in and repair the aneurysms and completely prevent the aortic dissections. Nobody needs to have an aortic dissection, and nobody needs to die of an aortic dissection if we can figure out who out there in the general population is at risk and put them on a clinical protocol to prevent those dissections. So my work has really focused on trying to identify the genetic risk for this disease. I'm having trouble advancing my slides. Let's see. And for many, so the first thing that I did as part of this research is really try to define what the genetics was of this disease. And what we identified was that there were patients, like patients with Marfan syndrome, where they had inherited an alteration in just one gene out of the 20,000 genes that we have in our genome. And that confers a very high risk for an aneurysm and a dissection. They're virtually guaranteed to have this disease as they get older. But we can find the patients with Marfan syndrome because they have very dramatic skeletal features. What's more difficult to find are people like John Ritter. He's a famous actor that was on a number of sitcoms. He died when he was filming a sitcom of an aortic dissection. And after his death, we imaged everybody in his family for asymptomatic aneurysms. We found an aneurysm in his brother, Tommy. It was surgically repaired, and 20 years after John's death of an aortic dissection, Tommy's still alive. And we have not found the gene in the family yet. And so we continue just to screen the family members at risk because we now know it's running in the family. So if you look at these people with Marfan syndrome or other syndromes that confer this high risk for aortic aneurysms leading to dissections, and look at these people that don't have syndromic features, that ends up being about 1 out of 5 patients with an aortic dissection. So 20% of them will have a risk. If we look at the other end of the spectrum, and like Richard Holbrooke, he was the Undersecretary of State to Hillary Clinton and actually dissected in their office. And this is Michael DeBakey. He dissected at 94, which is ironic because he pioneered the surgical repair of aneurysms and dissections. But this really represents 80% of the disease, and we're trying to find all the genetic risks here. We know in this population, hypertension, too much blood hitting the wall of that first part of the aorta is one of the major risk factors, but we think that combines with genetic risks too, and we really want to find these. But we'll talk mostly about these familial risks here that are there in 1 out of 5 families. Now, my lab and others have identified a long list of genes that predispose to this. You can now if you have an aortic dissection, we recommend you be tested for all these genes. And if you find the gene, if you are identified to have an alteration in one of these genes, it becomes very powerful information for you and your family. And we know these alterations are inherited in what's called an autosomal dominant manner. So if you are found to have one of these genetic alterations with any child you have, there is a 50% risk you will pass it on to that child. So this is a pedigree where women are circles and men are squares, not surprising. And if somebody's married, these lines down go to their children. And here we're showing affected people in green. So this mother passed the disease on to 3 out of 5 of her kids, classic for autosomal dominant inheritance. Once a child has it, they're at risk of passing it on to their children. But if a child doesn't have it, their children are not at risk. So we can go through a family, and if this is an EPN1 mutation that causes Marfan syndrome, oftentimes we can use the skeletal features, but oftentimes we cannot, and we need to rely on the genetic testing to find the family members at risk. And certainly for genes like the majority of families that don't have syndromic features, we're really reliant on the genetic testing, but we don't know all the genes. So like in the Ritter family, we know it's running in the family, and we just have to do routine imaging for those aneurysms. And we can prevent dissections without even knowing the underlying genetic cause running in families. So the second way that knowing the gene is powerful information is because we have to manage your aortic disease and other complications based on the individual gene that's altered. And so if we start with FBN1 and Marfan syndrome, we know that your typical Marfan patient will grow very tall with long arms and legs, at risk for ocular findings, so we have to watch the eyes. And then for the aorta, we monitor the aorta, and we know that they're at low risk for dissection until the aorta gets twice its normal diameter, around 5 centimeters. And then once we go and repair that aneurysm, we don't really have to worry about them going on to have aneurysm in their brains or elsewhere in their body. So we don't routinely image them for other aneurysms. But the case is very different for this set of genes. These are genes that cause Loeys-Dietz syndrome. And in that case, we know that we have to manage them very differently. First of all, they can, if a patient with Loeys-Dietz can be born with changes in their skull that alters their facial appearance and have other congenital defects involving their feet and other organs. And on the other hand, there's some people with Loeys-Dietz that look like classic Marfan syndrome, like this young man, but the majority look completely normal, and you would not pick them up in the general population. So there's a wide variety when we're talking about Loeys-Dietz syndrome. And these children are at risk for having dissection in childhood, whereas this woman had her dissection in her 40s. So the wide range of the age of onset with the different Loeys-Dietz genes. But in addition, we know that we have to be much more aggressive on repairing the aneurysm. For many of the Loeys-Dietz genes, we have to, just when the aorta just has minimal enlargement, we'll go in and repair it. And then after we repair it, we have to routinely image for other aneurysms in the brain and branches off the aorta. So very different management from Marfan syndrome. So when I talk about gene-specific management, that's what I mean. Like if we take a Loeys-Dietz patient with a TGFBR2, we and sit and treat them like a Marfan patient, that they will dissect before they reach 5 centimeters. And now we know we have to come in and be more aggressive about that surgical repair to prevent dissections. So who needs genetic counseling? So first of all patients with an aneurysm dissection need to know that one out of every 5 will have it running in the family. And it's a recommendation to image all the first-degree relatives of people with dissections. So that means the parents, the siblings, and the children. And then if you find let's say somebody, a brother has an aortic dissection and his sister is found to have an aneurysm, then you need to image her children also. And that's called Cascade testing. We also recommend genetic counseling and genetic testing for anybody with those Marfan Loeys-Dietz syndrome, if there's a family history of the disease, and for all dissection cases. So our yield of genetic testing for dissection cases is about 10%. 10% of dissection cases, we can find the gene. But if you look in aneurysm cases, that yield goes down to 1 to 2%. It's much lower. And then if you have genetic testing, a family history and genetic testing is negative, we do like we did with the Ritter family. We image the family members and manage the disease based on what happened to the family members. We have not found all the genes. So if we take somebody with a family history who's affected, only 30% will have positive testing. So we have a way to go to find all the genes. So, and as I said, if the testing's positive, it's very, very powerful information for the affected individuals and the family, because we can figure out who else in the family is at risk and prevent dissection and start gene-based management to hopefully prevent not only dissections, but in the case of Loeys-Dietz syndrome, a rupture of an intracranial aneurysm that could cause a stroke. Because the vascular system is plumbing. We can go in and fix aneurysms as they appear. So we just need to figure out who to image and where to image them, and then set them up on protocols to repair the aneurysm. And then if the testing is negative, all first-degree relatives should still be imaged and make sure they don't have those asymptomatic aneurysms. So thank you very much.
Thank you very much, Dr. Milewicz. We have a question from a participant who says, how do I get started with genetic testing or involved in the MAC registry as a spontaneous type A/D survivor with no answer 6 years out? Where do I get started? What do I do?
Talk to your doctor about genetic testing. If you had a dissection, the recommendations are that you undergo genetic testing. I wrote into the guidelines, the US guidelines, to test people under the age of 60, because we only at that time had data for dissections under 60. Now we have dissections of older people, and the rates of positive testings are the same. So we still get a 10% yield. So you should have genetic testing. And if that's positive, then it can be used to screen your family members. But then also your family members, if the testing's negative, you still need to check your family members and make sure they don't have those asymptomatic aneurysms. So start with your doctor, and in particular with your cardiologist for the genetic testing. And they should be able to provide, either do the testing themselves or provide a referral to a geneticist. Remember that right now the testing costs less than one echocardiogram and much less than a CT or MRI. So there's really not any reason not to go forward with the testing.
That was another question one of our participants had around the cost. So that's very helpful. Thank you. And in the case where it's not advised by your family doctor, or the person you're seeing for treatment, should you then pursue that and request it if it's not something that's being offered to you?
I mean, the reason for writing the guidelines is that you can take them to your physician and say, these are the recommendations. And guidelines are written to standardize care across the US and across Canada, so that you have that information and you can take it to your physician and, argue with them if they say, no, you don't need genetic testing. And the other thing about genetic testing is that they do have direct to consumer testing. And Invitae offers that in the US, and they will do it for Canadians also. And that in that case, they send you a tube, you spit into it, they do the testing, and then part of the bundle that you're paying for is counseling after that.
That's great.
That's another option.
Yeah, that's great advice. If we have time, we've had a couple of questions come in at the last minute.
Okay.
I have the ACTA2 mutation and recently found out that I have a mast cell disease named HATS. Do we know if there's a connection between the two diseases?
I don't. I think I don't think the ACTA2 mutation caused the mast cell disease. It's not a known complication of an ACTA2 mutation, but at the same time, one of the reasons I direct the MAC registry is that, we just found the ACTA2 gene 10 years ago. And so we don't know all the complications. And so people with known mutations, please contact me about participating in MAC if you want to participate. If you live in Canada, we can go ahead and register you directly into the MAC consortium. If you live in Toronto and are followed by the Toronto surgeons, they can enroll you through their surgical program. And I think the surgeon who's talking next will be remind everybody of that. But feel free to contact us if you have a known mutation in any of these genes that I talked about, because and to participate, you do not have to leave your house. You just have to allow us access to your medical records on aortic disease. And then, and from that, we can find out exactly what gene you have mutated and what the mutation, the alteration is, but also what kind of medical problems you had related to that. And then we get all that after we go through the study and consent you and you agree to participate. So please contact us if you're interested. And you will talk to Ernesto, Dr. Ernesto, and he will go through what, what it means to participate in the study, and then you can decide if it's right for you or not, and then move forward.
Yeah, and I would add for anyone listening or anyone listening in the future to the recording, they can reach out to our info@gadacanada.ca, and we can direct them to you and to your team.
Exactly.
Okay. We are a little bit good for time. I have a couple of questions more here. When you say imaging for first-degree family members, what kind is best to monitor aortas?
If you know your relative has an aortic root aneurysm, then an echo would be fine. If it involves the ascending aorta, sometimes on echo they can see the root is the very first part of the aorta, but sometimes the aneurysms are further up the aorta, further up higher into the more towards the neck. And sometimes that's hard to see by echo, and you have to go to a CT or MRI.
Okay.
But I would start with an echo, especially if you know your family member had that first part of the aorta enlarged.
Okay. And one more question here. Can you speak to Moya Moya and ACTA2?
So there's the ACTA2's turned out to be one of the most interesting genes, I think, because it causes not only aortic aneurysms and dissections, but it also causes a disease called Moya Moya disease and early onset atherosclerosis like coronary artery disease and heart attacks. And we've been working on trying to figure that out and really be certain which variants cause what additional diseases. Because once again, we can prevent and hopefully prevent complications like heart attacks if we know who is at risk. And there's just certain mutations in ACTA2 that cause Moya Moya disease, and only two prominent mutations. And we're starting a clinical trial to try to prevent the Moya Moya disease using data from our mice models and our cellular systems. And we are just starting this clinical trial. So please, once again, contact us about MAC if you know you have a mutation that causes Moya Moya and ACTA2, because we're recruiting the patients from the study from MAC itself. So the people that'll be on the clinical trial, and it won't be a blinded or a placebo control. We're going to put, it's a relatively benign treatment. So we're going to start with putting everybody on the treatment and see how they do.
Okay, that's great. I'll just double check if there's any more questions. We have one final question for you. Is there any research into therapeutic strategies to address the actual weakening of the connective tissues, perhaps in the form of supplements?
There's lots and lots of research. I don't think supplements will be the answer. There is a lot of research, and there's a lot of good clinical trials coming out in terms of what protects individuals from aortic dissections and aneurysms and problems with the arteries in patients like low estates and beds. So I'd say support GADA, will allow you to support research in this area so we can get more of these clinical trials. And once again, the MAC registry gives us automatically patients that can be approached about clinical trials. So if you're
Yeah.
interested in participating, that might be another reason for joining MAC.
Yeah, I think that's one of the most important messages. That's also empowering for patients in our community, that they
Right.
can reach out directly.
Exactly. Okay,
Yeah.
I'm going to dock off and let somebody else talk.
Okay. Yeah, thank you so much, Dr. Milewicz. We really appreciate it. Okay, so at this time, I'd like to introduce Dr. Jennifer Chung. She's a highly respected cardiac surgeon specializing in aortic surgery. Do we have our slide up here? There it is, okay. Forgive me one moment. She's a highly respected cardiac surgeon specializing in aortic surgery. Dr. Chung is the director of the Thoracic Aortic Surgical Clinic and a cardiovascular surgeon at the Peter Munk Cardiac Center, University Health Network in Toronto. She is also an associate professor at the University of Toronto and a co-program director of the Advanced Aortic Surgery Fellowship. Dr. Chung holds the Melanie Munk Professorship in Aortic Biomechanical Research, where her innovative research focuses on the biomechanics of the aorta to better understand why and how exactly aortas fail. Her work is at the cutting edge of combining engineering principles with cardiac surgery, making her a key figure in advancing the field of aortic surgery. While Dr. Maral Lazunian, who was originally scheduled to join us, could not attend due to a scheduling conflict, we're extremely fortunate. I'm grateful to have Dr. Chung here today as she works closely and daily with Dr. Lazunian at the Peter Munk Cardiac Center. Welcome, Dr. Chung.
Thank you very much, GADA Canada, for the invitation. Thank you, Linda. So
You're
I'm going
welcome.
to share my slides here. So it's a pleasure to speak to everyone here about surgical treatment of aortic dissections. So the previous speakers, Dr. Thorne has already gone through the differences between type A and type B dissection, but I think it's worthwhile just to bring it up again because it does have implications on what type of surgery or medical therapy that you get. So just to briefly reiterate, type A dissections involve the ascending aorta, and it can include the whole aorta itself, as long as the ascending is involved. And type B dissections are the descending portion of the aorta that does not involve the ascending. So as you all are very acutely aware, that aortic dissections is a very lethal condition, and that is because the aorta is the major highway of the body. It supplies every downstream organ, and so when it's compromised, blood flow can be cut off to any organ, including the heart, the brain, the spinal cord, the guts, the kidneys, the legs. If you have a type A dissection, which is the type that affects the ascending aorta, as was very eloquently described by Dr. Thorne, it does require immediate surgery, and so time is of the essence. Why is the ascending aorta such a vulnerable location of the aorta? That's because it includes the coronary arteries, which supply the heart muscle with blood and oxygen. And so if that is compromised, that causes a heart attack. If the ascending aorta ruptures, it's the most vulnerable part of the aorta to rupture, and then it will collect around the sac, inside the sac around the heart, and prevent the heart from filling. And if it compromises the head and neck vessels that are at the top of the aorta, then that can cause a stroke. And so these are the factors that we try to get at right away when we operate on a patient with a type A aortic dissection. So which parts of the aorta do we repair at the time of a type A dissection? We always have to address the ascending aorta, always. So the very minimal basic repair will include repair from the level just above the aortic root, right here, up until the start of the arch. So that whole segment of aorta must be replaced. Sometimes we also have to address the aortic root, and sometimes we also have to address the aortic arch. As part of aortic replacement of the ascending aorta, This is the picture on the left. The dissected aorta is now replaced with a synthetic graft. This is a Dacron graft, which and Dr. Milewicz pointed out this surgery was pioneered by Dr. DeBakey, and he invented this the fabric that we all use today, the Dacron tube, and this material is very strong and is very durable. You can also appreciate that the aortic valve has been repaired with these suspension sutures, and that's how we restore the function of the aortic valve that is often leaking during aortic dissection. The aortic root may also need to be replaced, and this is especially pertinent to patients with heritable thoracic aortic diseases, including Marfan syndrome. Classically, the aortic root is involved and is, in fact, the biggest part of the aorta. So in cases like that, the aortic root then also needs to be addressed. So if the root is very large, if the tear originates in the root, which is not that common, or if the root is extensively dissected, then root replacement is what we would then proceed with. So valve-sparing root replacement was pioneered in Toronto here in our center, as some of you may know. And what that procedure does is it replaces the aortic root with that same Dacron material, but then we sew up the valve within the graft so that you can preserve your own cusps. And then the coronary arteries are then sewn back onto the graft. So that's called a valve-sparing root replacement. Sometimes that is not possible, especially in the case of an aortic dissection where the patient is very sick and we don't have the extra time that we want to spend on doing the valve-sparing root. Or sometimes the parts of the aorta that's dissected really compromises the durability or repair of the valve-sparing root and we're not able to do it. Or there's primary valve pathology that prevents us from doing the valve-sparing root. So in that setting, then we replace the valve completely with the root in total, and that's called a Bentall procedure. And here in the diagram on the bottom, you can see that the Bentall procedure can be performed with both a mechanical valve or a tissue valve, and that often will depend on the age of the patient. So as mentioned earlier, aortic arch surgery may also be necessary. So we might replace we have to replace the ascending. Sometimes we replace the root, and sometimes we extend the repair downstream. So there are, it turns out, many options for repairing the aortic arch and the downstream aorta. And these are two examples. So on the left, you can see that the aortic arch, which is where those three arch branch vessels come off, have been replaced and the branches have been restored. And now a new stent graft is replaced into the descending aorta, and that's what we call a frozen elephant trunk. The stent graft is a fabric covered stent, and the stents have a capacity to expand inside the blood vessel at in your body temperature, and that's what it does. And it rather than the strategy of replacing the aorta, it takes pressure off of the aorta by directing the flow inside the stent graft. Okay, so that's the strategy there. So this effectively extends the repair downstream. You can also replace the arch as you can see, in various configurations. And you can also leave a conventional elephant trunk where it's not stented. So you can see that the elephant trunk that's left in the descending aorta does not have stents within it. And there are certain reasons why you may choose one over the other. You can have stent work done at the index operation, or you can have it later on in your hospital stay, or you can even be brought back later for extension of your repair. And there are many indications for the three various strategies. So when would we think about extending our surgery this much? This is if the tear is in the arch, in which case we really do have to resect that primary intimal tear. If the arch itself is aneurysmal and at risk of rupture, then we would have to replace that. And those are the main reasons, but softer reasons include if you feel that this is a very young patient and you want to set them up later on for their subsequent surgeries. In addition, if patients have malperfusion or compromise to blood flow downstream, then this is one of many effective strategies to deal with that. So type A dissection, after a successful repair, most patients will still have a residual dissection going downstream. I feel that this part sometimes isn't properly explained to many patients. After a successful repair, we sometimes only replace the ascending aorta and resect that primary intimal tear, but it doesn't mean that the rest of the aorta is not dissected. That part of the aorta can often be successfully managed with medical therapy, and although there is a significant reintervention rate if you follow patients long term. So it means that if you've had an aortic dissection, even if it was fully repaired, even if it was successfully repaired, it doesn't mean that you don't need lifelong follow-up. In fact, lifelong follow-up is absolutely necessary, and hopefully you can be enrolled in an aortic clinic close to where you live. So now moving on to type B dissection. So this is the type of dissection that does not involve the ascending aorta. This can be categorized into uncomplicated or complicated. So uncomplicated, as you can imagine, does not have rupture, compromised blood supply, these sorts of things, and it can be successfully managed with blood pressure control. These patients are often admitted to an ICU or a CCU setting, have invasive monitoring, make sure that blood pressure is well controlled, make sure that the pain goes away. Subsequent CT scans are done to make sure that it stays uncomplicated prior to discharging the patient home. Complicated dissections are obviously much worse and need to be addressed. So this is addressed with surgery, and it can be open or endovascular. So when we talk about endovascular surgery, traditionally it has been problematic in patients with genetic conditions because there have been many reports of complications. The aorta in patients with genetic conditions are more fragile, and so there are reports of inducing type A dissections, of causing new tears, or a very high rate of needing reinterventions. I think we are learning a lot about stent grafting in patients with genetic conditions, though, and it is more done and more commonly done, but with a lot of caution in very specific scenarios. And definitely in life-threatening emergencies, we have used it and successfully, knowing that we may need to reintervene later on. The alternative then is open repair. So if we can't do endovascular repair, then we do have to consider open strategies. And listed here are the different extents of thoracoabdominal aortic repair. This is a very extensive surgery that replaces large portions of your aorta. It's quite demanding. I'm happy to answer questions about it later if people have any. The bottom line is for both patients with type A and type B dissection, you require lifelong monitoring for the entire aorta. Aneurysmal degeneration can happen, and it's better to intervene on these electively than in an emergency setting. So to summarize, acute aortic dissection is a sudden and potentially catastrophic aortic emergency. Acute type A dissection requires emergency open heart surgery with replacement of the aorta. Acute type B dissection is often treated medically, but may require emergency endovascular or open thoracic or thoracoabdominal aortic repair. Survivors of dissection need lifelong monitoring of the entire aorta. Thank you very much.
Thank you very much, Dr. Chung. We have a couple of questions we'd like to direct to you. The first is coming from one of our participants live. Tell me more, please, about valve replacement, mechanical versus tissue, and how does age affect the choice?
The most durable valve replacement option that we have is the mechanical valve. So the rate of reintervention is very low, less than 0.5% per year. And so for a young person, this is a very good option. I think it's also nuanced. I'm sure Dr. Thorne can talk a lot about pregnancy and anticoagulation and all these other considerations. But generally speaking, it's a very, very good option for a young patient. Okay. Anticoagulation, though, is with warfarin, not with the newer blood thinners that you may have heard of. And warfarin does mean regular monitoring of blood work and so on. There is a certain bleeding and clotting complication rate per year when you are on this medication with a mechanical valve. The alternative is tissue valves, which you mentioned. It's a lot more hassle-free in the sense that you don't have to take warfarin for it. Baby aspirin is great. And for older patients who don't necessarily need that long-term durability, the lifestyle benefits are far outweigh, the durability aspects, and it's a very, very popular option. There are other ways of the problem, of course, is that it wears out, and you may need another surgery in 15 years or so. And so that's a concern in younger patients. That being said, there are some other options for reintervention now. If you are, say, 75, it's actually a very great option.
Yeah, okay, thank you for that. The next question. So this comes from a live participant on the call. I've had both root repair and what I remember as a TAAA. Please explain TAAA.
Well, TAAA generally stands for thoracoabdominal aortic aneurysm repair. And so that's when your descending thoracic and abdominal aorta is replaced.
Okay. Make sure we answered
the
there wasn't really a direct question there, but we have a couple of more here that we can move on to. After a rebuild of the aorta, is it normal not to feel like the same person anymore? Feel like you have changed and many physical preferences have changed? This can kind of border onto a question we could also address with our next panel expert, but someone's addressed it specifically to you, so I wanted to bring it up to you in terms of outcomes with your patients. Have you heard that before? Maybe that's a good way to approach answering it.
I think that so for sure it depends on the type of surgery. So for thoracoabdominals, we definitely try to prepare the patient that the recovery road is long after a thoracoabdominal. And for sure there's a lot of you're not necessarily I think it's normal to feel like you're not quite yourself. And even it takes good 6 months for even the youngest of our patients, to recover. So if you're just a few months out, obviously give yourself some time, and talk to your physicians, make sure they investigate and that there isn't something more than just time that's needed. For a type A dissection, I really feel that the next speaker is very valuable because we definitely have had many patients who are profoundly affected, obviously, by their diagnosis. And so even if somebody tells you, well, you didn't really have a complication, but you recovered well, but absolutely it's not it's
just physical.
I would say that you're not alone for sure.
That's a great answer. Thank you. The next question is, how do you know when surgery is appropriate? I have a dilated aorta that measures 49 millimeters. When is the right time?
So, I mean, it's tricky, obviously, because I don't know this patient. I think they should talk to their doctor because there are many things. So Dr. Milewicz is an expert in genetic disorders. If she identified a specific gene for you that made you particularly vulnerable, maybe 49, you should operate, you know, versus
Yeah.
somebody who has a family history where their dissection occurred at a small size, then for sure, maybe that's 49 is appropriate. For the run-of-the-mill sporadic aneurysm that we see, we generally wait until it's after 5, unless unless we have evidence of growing quickly or something else.
Yeah. For those of us, the next question, for those of us who have underlying lung conditions, what can we do to prepare for heart surgery?
We've started sending we've been sending for a number of years now patients to prehab, and this is particularly good for our thoracoabdominal patients who, especially if you're older, and like we've sort of hinted at, it's a big surgery. It takes a lot to recover from it, and so it's like the rehab program, but it's prehab, and so you meet the same people, and they give you the same exercises and prepare you, and they'll do exercise testing with you and these sorts of things, and give you the elastic bands and get you to build up your muscle strength. And patients, it's actually, I think, empowering for the patients because they're taking control and they're taking ownership of it. And I love reading the notes from the prehab people and the progress that they're making. So that's something I would consider doing.
Yeah, that's great advice. We have a couple of more questions here. What is the surgical threshold for abdominal aneurysm with dissection with Marfan, and is the rate of growth considered?
So abdominal, I'm guessing this is a chronic aneurysm that we're talking about that is dissected. It's, it's hard to know. So it depends on where the aneurysm is as well. Infrarenal versus juxtarenal versus thoracoabdominal carry different risks and different, so that varies. Women, varies from men. Generally speaking, we use lower thresholds for women than we do for men. I hate to give this answer, but I'm not going to give you a single number. There is a nuance to sizing,
Yeah, and I would say to anyone listening tonight or listening in the future, if they have specific questions, though GADA is not qualified to give advice, what we can try to do is connect people to other experts if they're having trouble finding resources or getting answers. If we haven't answered anyone's questions completely tonight, feel free to reach back out to us via email. And this is the last question. I've had both a type A and emergency repair and the frozen elephant trunk surgery also. Will I likely be on ASA 81 milligrams for life?
We would, yes.
Yeah. Okay. Thank you so much, Dr. Chung, for taking the time and for answering all the different questions. I really appreciate your time this evening.
Thank you very much.
So our next expert panelist is Dr. Jeff Daskalakis. I'm pleased to introduce him. He's a renowned psychiatrist and an expert in treating severe psychiatric disorders. Dr. Daskalakis is the chair of the Department of Psychiatry at UC San Diego Health, where he leads cutting-edge research in brain stimulation techniques, particularly transcranial magnetic stimulation, for treatment-resistant conditions like schizophrenia, depression, and obsessive compulsive disorder. Before joining UC San Diego, Dr. Daskalakis was a professor of psychiatry at the University of Toronto and co-director of the Temerity Center for Therapeutic Brain Intervention. His work has had a transformative impact on how we understand and treat mental health conditions, especially in cases where traditional medications and therapies fall short. This evening, Dr. Daskalakis will be sharing insights on the mental health challenges faced by those affected by aortic dissection, focusing on anticipatory anxiety and post-traumatic stress, grief, as well as depression. We're very fortunate to have him here to shed light on these critical issues. Please join me in welcoming Dr. Jeff Daskalakis.
Thank you for the kind introduction. Really appreciate the opportunity to be able to speak to this group. I'm just going to share my slides. There we go. Everyone can see that?
Yes.
Okay.
Perfectly.
So just want to begin by highlighting that cardiovascular conditions represent, as we all know, a profound and sometimes existential threat to our patients. That is that the idea of having this risk that could take your life at any moment is profoundly anxiety provoking. And this is just a slide which suggests, provides evidence underscoring that point, that patients with Marfan syndrome patients with acute aortic surgery were much more likely to experience anxiety. There's nothing earth-shattering here, but it just quantifies the fact that patients who have Marfans with aortic complications, or patients with cardiovascular disease in general, could potentially struggle with anxiety and depression. That's where the domain of the consult liaison psychiatrist comes in. The consult liaison psychiatrist is a psychiatrist who works in a general hospital as opposed to a psychiatric hospital. And that psychiatrist's job is to evaluate patients and evaluate the behavioral health or mental health aspects of patients who are experiencing who are undergoing a medical condition, maybe experiencing psychiatric sequelae as a result of that medical condition. So what are the psychiatric aspects of heart disease? Well, I certainly mentioned one, which is anxiety, and it's very frequent in acute coronary events and arrhythmias. In fact, in some cases, the arrhythmias themselves can cause anxiety. Anyone who's ever experienced a premature ventricular contraction, a sudden skipped beat in their heart, is aware of the experience. And someone who has that experience over and over again, that experience in and of itself may become reinforcing and trigger an anxiety event. But anxiety itself can trigger that event. So it's kind of a vicious cycle, that the anxiety triggers the premature ventricular contraction, which then triggers more anxiety. And before you know it, you could have runaway anxiety, which causes significant difficulties in someone's quality of life, and they need to get treatment for. Anxiety also, by virtue of the fact that it is a significant stressor, causes cortisol levels to go up, causes adrenaline levels to go up, and that may adversely affect outcome in coronary artery disease. And anxiety after MI is very common. It's frequent in episodes of unstable angina, and anxiety after a person's had a large MI is extremely frequent and needs to be carefully considered. Some people can be resilient enough to not experience anxiety. Most do experience some degree of anxiety. The question of whether or not you need to intervene with medications versus what we call talk therapy is something left to the consult liaison psychiatrist. Also important to consider that anxiety, when medicated, can change the heart's ability to function, both insofar as some of the electrical abnormalities or electrical changes that take place in the heart, but also in relation to the ability of the heart to produce sufficient enough pressure to be able to pump blood through the arteries and through the body. Now, there are also psychiatric aspects of heart disease. That is, if you're enduring depression, major depressive disorder, you're more likely to experience coronary artery disease as a result of that major depressive disorder. The state of being depressed in and of itself raises all those stress hormones that could put you at risk for coronary artery disease. Depression is also very common after coronary artery bypass surgery. And so about 30% of patients experience that. Depression is common after congestive heart failure. And in and of itself is a risk factor for the development of coronary diseases, as I mentioned. Depression quadruple the relative risk of cardiac mortality in those with heart disease. So it's something to be very mindful of. And most medical specialties, as we heard already, are acutely aware that calling in psychiatry when their patients are experiencing what looks like behavioral health change is a priority and of paramount importance, and why many large health centers have psychiatry available to manage and evaluate those patients. And depression itself is a predictor of mortality after MI, with a threefold increase in risk of death. And that is that if you're depressed after you've had an MI, the chances of dying is significantly elevated. So something to be really thoughtful about and be on the lookout for in our patient populations who have endured medical coronary conditions. Being able to intervene early also enables us to help patients in their recovery, give them quality of life, and improve, obviously, their outcomes. But it's not all positive. Medications are also associated with side effects. The older medications, tricyclic antidepressants, which are not often used, have attendant side effects associated with them, including orthostatic hypotension, conduction abnormalities. They can cause sinus tachycardia, supraventricular tachycardia, ventricular arrhythmias. The list is on and on. Now, that's not to say that they're high risk of causing these abnormalities, but the risk is certainly there. So we have, since in the last 20 or 30 years, have pivoted away from tricyclic antidepressants, although they're still sometimes used, towards serotonergic agents. And serotonergic agents, of course, we've all heard of those. Those are the Prozacs, the Zolofts. Those are very effective medications, but in some cases, there have been attendant side effects associated with them, including vasoconstriction. And venlafaxine, which is a commonly prescribed serotonergic agent, serotonin and noradrenergic agent, can cause blood pressure elevations. So all this to say that we routinely use medications when we need to manage the psychiatric sequelae of cardiovascular disease. Be that as it may, I think we're also on the lookout for the side effects of these medications, and we monitor these very, very carefully. In fact, one of the things that we monitor the most is something called the QT interval, or the corrected QT interval, to be more specific. And I'm in the last few years, although historically I didn't do a lot of consult liaison work, since I moved here to the University of California, San Diego, we have such a large healthcare system. There was a need for additional CL support. And as chair, I rolled up my sleeves and started seeing patients on medical unit. It's one of the best things I did. It was a rewarding experience. I got a chance to practice a dimension psychiatry that had eluded me for many years, just because I was in a psychiatric hospital, and learned to be really attentive to QT interval changes, because the problem with QT interval changes is it can lead to much more worrisome arrhythmias in patients. And so we carefully monitor risperidone, haloperidol, olanzapine, ziprasidone, to some extent thyroidazine. They're all medications that we use in a medical setting. Why do we use them? Well, we can use them in patients who are confused after a large surgery. We heard about thoracoabdominal aortic aneurysm repairs. Those large surgeries and all the attendant interventions, replacement of the aorta, the medical interventions, the need to intervene with medications, are frequently associated with confusion in those patient populations. And what you see is patients, even young patients who are recovering, who have developed what we call delirium. And a delirium is just a fluctuating level of consciousness. People don't know necessarily where they are. They may misinterpret things around them. They may have unusual sensory experiences, and their cognition may be compromised, which is quite a frightening condition for a patient. And typically, when patients get agitated, we intervene sometimes to help calm patients down. But there are these attendant side effects that are associated with them that we monitor very, very carefully. And of course, hypertension is also a medication side effect, drop in blood pressure, especially in a cardiovascular patient, that we have to be really mindful of. So there is considerable overlap between psychiatric and medical care, psychiatric presentations of medical conditions, medical presentations of psychiatric conditions, and then, of course, all the medical complications and psychiatric complications associated with medications. I mentioned the psychiatric the medical complications of psychiatric treatment, but there are a number of medications that also cause psychiatric conditions that we have to be careful of. The one that most people have heard of is using steroids and having significant mood changes, perhaps even psychotic symptoms associated with steroid use. So just something that we have to be really careful about. I mentioned steroids, the euphoria, mania, psychosis, depression that sets in. Prazosin is a medication that helps drop pressures, but we also use prazosin in post-traumatic stress disorder. Its use has been sometimes associated with drowsiness, sometimes depression, nervousness, although typically it helps reduce nervousness. ACE inhibitors are used to control blood pressure, but they can have been known to produce depression, somnolence. Now, remember, I list these as potential side effects. I think it's important to bear in mind that just because they're listed doesn't necessarily mean that they happen at high rates of presentation. That is, that the presentation of the symptoms can be really small, sometimes in the range of about 5 to 6%. So we're not talking about this happening in 50% of our population, but it can happen in 1 out of every 10 or 20 patients. Cyclosporin is an antibiotic that can cause confusion, but not typically used. And beta blockers are notorious for having an assortment of psychiatric sequelae, most notably depression, something also to keep in mind. I mentioned the side effects of medications, psychiatric medications. Serotonergic agents can cause an assortment of side effects. Antipsychotics can have blood pressure changes and can also lead to hypotension, and there's other more disconcerting side effects associated with antipsychotics, including neuroleptic malignant syndrome, which we don't see often, thankfully, but when we do see it, it is a medical crisis that needs rapid intervention. So what about depression? Well, stress typically exacerbates anxiety and can sometimes lead to depression. And depression is a disorder that affects millions around the world. It leads to tremendous functional impairment, surpassing many of the chronic medical conditions that we've described today. It's the leading cause of disability in North America. It's the second leading cause of disability worldwide. And it has enormous economic costs on society. It's estimated that it leads to about $200 billion loss in productivity every year, not to mention the personal suffering that patients endure. This is a paper that we published now several years ago, but it was a paper that was led by my graduate student, my resident at the time, who's now a psychiatrist at the Center for Addictional Health, Helena Kim, who was an outstanding resident. And she looked at the effects of medications on patients who had comorbid physical and psychiatric disorders, and found that in depression, in patients who had medical or comorbid psychiatric disorders. So, for example, if you had depression in the context of severe substance use, or depression in the context of Marfan syndrome, that you are less likely to respond to the antidepressant medications than not having those underlying conditions. So it's important to bear in mind, because some of these treatments do work very, very effectively, but there are times where they don't work as effectively, which gets us into the domain of resistant depression, which is depression that takes place in about a third of patients, of course, higher in patients who have comorbid medical conditions. Depression typically translates into rates of hospitalizations that are twice as high. It leads to 3 times the total medical cost for 3 times more psychiatric medications, and 6 times the total medical cost. In fact, I've seen numbers as high as 19 times the total medical cost. And relapse rates are high. That is, even if you do respond to treatment, the likelihood of relapse at 2 years is quite high, significant. And then there's the most disconcerting aspect of depression, which is suicide, which can have huge impacts on a person's life. Again, an existential threat. Nearly 4,000 Canadians, 40,000 folks in the US die by suicide every year. That's more than 10 suicides a day. More than half of suicides involve people who are 45 and older. And it is a huge public health problem that we're grappling with. And the data are even more sobering because rates increase as people get older. And in general, rates of suicide have been increasing. These are data that ended 2014, but I've seen most recent data which suggests that even beyond 2014 and into 2024, 10 years later, rates of suicide continue to increase. So in conclusion, MARFANs and other cardiovascular diseases are associated with considerable comorbid anxiety, and we have to be mindful of them. The good news is that medications do work, as does psychotherapy, and it's something that I didn't spend a lot of time talking about. Perhaps psychotherapy is one of our most valued and intervention of greatest impact, because it is basically associated with very few side effects and can be used incredibly effectively. Things like CBT can be used and are very powerful when used to treat anxiety and depression. Advanced treatments may be needed. One of my areas of expertise is in interventional psychiatry, which includes transcranial magnetic stimulation, and we're now starting to see trials which are used in medically comorbid patients with very strong therapeutic effects. In fact, we're leading up to a trial here at UCSD to be able to examine depression and anxiety treatment using these new devices. And finally, CL psychiatry may have a significant role in reducing distress and burden. And the reason that CL psychiatry is used in general medical settings is because of the high rates of comorbid psychiatric illness in medically ill patients. Thank you for the opportunity to present, and delighted to answer any questions you may have.
Okay, thank you so much, Dr. Daskalakis. We have a few questions. The first question comes from one of the participants on our call, is submitted it live. I have never heard of a consulting liaison psychiatrist and didn't have one supporting my surgery. It seems like an obvious need. Why isn't this a standard practice at more medical centers?
That's a great question. If you're in a large academic center, most large academic centers do have psychiatrists who have subspecialty expertise. For example, in Toronto, I know Toronto is really the epicenter, the center of gravity for CL psychiatry. Most of CL psychiatry had been developed and quite mature services, even as dating back to the 1990s when I was a resident. Mm-hmm. In smaller centers, the CL psychiatry typically is serviced by psychiatrists who haven't had the additional fellowship training. In the US versus Canada, the cost structure for CL psychiatry is also very different, and maybe the reason why we see fewer CL psychiatrists compared to the Canadian healthcare system. Something for consideration down the road. But just to say that psychiatry is a service that's provided nowadays, especially in the US. We're seeing a lot of nurse practitioners fill the role of the consult liaison psychiatrist, and they do an absolutely exceptional job. The most important piece to that is making sure that behavioral health care needs are managed by someone who specializes in behavioral health, including a psychiatrist or a nurse practitioner. But it is something that needs to be considered. Now, a lot of physicians may not necessarily identify the psychiatric condition, or if they do identify, recognize that it's a condition that resolves quickly. So they may not necessarily call in a psychiatrist right away. It's only when the condition fails to respond to conventional treatments where psychiatry is often requested.
Okay, thank you for that. Question here, how do you recommend treating ADHD in vascular patients?
Oh, that's a good question. It's something that I also work in an outpatient medical setting, supervising residents, and we see a lot of ADHD. And ADHD, it's becoming and people, the awareness of ADHD is becoming far more commonplace. And so
Yeah.
we're getting a lot of requests from folks, you know, ranging from their late teens all the way up through to 70. We have patients who recognize that they have ADHD who are over 70 and request treatment for it. ADHD medications work extremely effectively. It's perhaps one of the most effective treatments we have for psychiatric disorders. That is, if you have ADHD, psychostimulants work very effectively. The challenge, though, is that they are also associated with significant side effects. And one of those side effects, because they're stimulating, can increase blood pressure, increase heart rate. And over time, there are sequelae that are associated with that. Not, you know, just increases in blood pressure, but it's the features of blood pressure, long-standing blood pressure increases, which are risk, dissection being, of course, one of those. Add to that, there may be other side effects associated, arrhythmias, et cetera, that are undiagnosed that may be provoked with these medications. We need to be real careful about their use, which is oftentimes why we carefully monitor medical blood pressure, monitor for any arrhythmias through an EKG, and certainly screen for them when patients are being evaluated.
Okay, thank you. This is a big question, and I'm sure it's a big question for a reason. Mental health after diagnosis of aortic aneurysm. Where and how is the best place to get help, given that these conditions are rare? There's probably a lot of people that don't know what to do or where to go right away.
There's lots of places that you can go to for help. Obviously, the first place is the doc who's involved in your care for the cardiovascular condition. So we have experts on the call. They manage patients, and if anxiety or depression is raised with those docs, or with the doc that is managing your condition, it stands to reason that if the condition is severe enough, that you would be referred. In many medical settings nowadays, we're using screening questionnaires, including the GAD, the Generalized Anxiety Disorder Scale, the PHQ-9, which is the Patient Health Quality Scale, which really evaluates a person's underlying depression, anxiety. And those scales also give us insight to whether or not people are feeling suicidal. When we have that information, and those are routinely used, they're routinely used in general medical settings, they can trigger evaluations by psychiatric specialists, and some of that care involves a warm handover to the psychiatrist or the behavioral health expert, who can then manage the psychiatric aspects of the medical condition. Be that as it may, I think it's important that if you haven't been screened and you're experiencing those conditions, you can even reach out to your family doctor and report your symptoms, because the family doctors often have a wealth of resources that they can turn to refer. That's the good news. The bad news is that it's hard to find a psychiatrist these days or a behavioral health expert. Getting a referral and having a referral translate into an evaluation can take months.
A very long time.
Yeah, that's months of patients enduring symptoms. I wish we had a better answer to that. I wish referrals could happen quickly, but you know, if it really gets bad and to the point where you're experiencing depression and suicidality, which doesn't happen oftentimes, but if it really gets bad, then you know, your emergency department is probably the best place to go to.
Yeah. Okay. Just gonna scan to make sure we. Another very general question, but likely something that many people experience. How do I manage daily anxiety with a residual dissection? I feel like I'm a ticking time bomb.
I mean, what was just described is something that I mentioned right at the beginning, which is, you know, this existential threat. There are ways of managing the anxiety. CBT is one way of overcoming the fear of having this idea of having a ticking time bomb issue is to know that it's not going to happen imminently, and working through some of the anxiety actually can prevent the worsening of your condition. So not only is it important to get the help from a psychiatric perspective, but it's also important from a cardiovascular perspective to have some of those symptoms attenuated. So I would say get the help that you need. There are many medications that are extremely effective in these conditions, and also talk therapy. Not to, I often speak about talk therapy as being almost like an afterthought, and that's simply not the case. These can be very powerful interventions and help people get their arms around the condition and know how to manage the symptoms.
Absolutely. Okay. We have one final. This was more just a comment. This is a comment, but participant live says that they've experienced a wide range of psychosocial challenges post-dissection: elation at being alive, and then depression when the elation wears off, relationship changes, PTSD in family members or spouse who witnessed the event, neurofunctional changes impacting day-to-day functioning, and identifying as disabled due to a stroke. While most people don't see it, mental health issues were the greatest challenge, as opposed to the physical rehabilitating from the mental health issues. It's why we were very, very happy to host you today, and it's an important part of recovery and living with a chronic condition.
Agreed. It's important to raise awareness. When I was a resident, I recall seeing these huge surgeries, and at that time, psychiatry was just simply not considered in the calculus when it came to patient outcomes. And fortunately, things have changed, and now we're acutely aware, and not only are we aware of the condition, but there's been a lot of research done to intervene effectively, and so there are great options out there.
Yeah. Thank you so much for your time today.
Thank you, everyone.
I think that we were able, in fact, with this format, to try to answer nearly every question, and a couple of questions we didn't specifically pose, I believe that they were answered in various other ways. If you have any questions that were not answered or that you did not get to us in time this evening, please send them to us at info@gadacanada.ca. We'll do our best to try to answer those questions for you. I would like to say in closing, thank you to everyone for joining us this evening. We are incredibly grateful to our expert panelists for sharing their insights on diagnosis, treatment, genetic testing, and mental health management. So a very special thank you to Dr. Sara Thorne, Dr. Dianna Milewicz, Dr. Jennifer Chung, and Dr. Jeff Daskalakis each of you for your time and your contributions to tonight's discussion. It is really through events like this that we hope to empower individuals, families, and healthcare professionals with the knowledge and the resources needed to try to better understand and manage, specifically in this case, genetic aortic disorders and the complications and impacts that arise on the individual and the families as a result of those conditions. We encourage you to stay connected with GADA Canada for future events, resources, and any updates. And remember, if you have any other questions, please feel free to reach out to us through our website. Once again, thank each of you for attending, and to our panelists for their participation. Have a great evening and take care.